All right, I hope you all enjoyed that. I know the first time I saw it, it really, so many light bulbs went on, and that was kind of one of the very first things that prompted me to put my pen to the paper and start planning this day, because I thought everyone here needs to hear this message, and there's so much that we want to pack into this day. So again, thank you for being here. Okay, so for those of you who are not familiar with me, I am Dr. Michele Couri, and again, incredibly grateful and honored to share the day with all of you. This day really is taking control of your health. It's about gaining knowledge and science and the ability to make informed choices about your health. So that's our goal. We want to empower you with a lot of knowledge. And before I begin my talk, I just want to take a moment to thank some very important people that need to be thanked. First, a huge thank you to Myriad Genetics. They are our visionary wellness sponsor, and their generous support means the world to us. To my incredible co-host, Leslie Roosh-Bayer, her passion and dedication shine through in everything that she does. And to all of our speakers, some of whom have traveled from far away to be here, we really are grateful that you made the effort. A huge thank you to Allison and Willow and their entire team at Envision Events, and for their entire vendor team. Their creativity and their detail-oriented approach and their organization really helped put all the pieces together and make this happen, so thank you. To Cheryl, our marketing director, she's in the back of the room. Her countless hours of hard work and going above and beyond and basically just putting up with me. I can never thank her enough, so I appreciate it, Cheryl. To Kyle and his team here at Holiday Inn East Peoria, they've been more than accommodating, and I really appreciate all their help. I was meticulous about making sure that the menu was healthy and delicious. And gluten-free for those who need it. So they were really, really accommodating, and I thank them. For our entire staff, many of whom are here today, they are my backbone, and they are the most talented staff anywhere, and I'm just grateful that they're here on a Saturday helping us out. To all of our vendors that are here as well, please take some time to visit their tables. We appreciate their willingness to be a part of this event. They've got some really important things to showcase. To my husband and kids, many of whom came in from college to be here this weekend, so thank you so much. It means the world to me. But most of all, really, thank you to all of you. You're the reason we do what we do, and you're the reason why we're here today. So thank you. Really just, my heart is full of gratitude, so I really appreciate it. So now let's kind of start my portion of the talk, and I chose to title my talk, "The Truth About HRT," because for far too long, in my opinion, hormone replacement therapy has been hijacked by a lot of misconceptions and fear and controversy. And I've been fighting this my entire career. I graduated from residency and started my practice in 2001, and the Women's Health Initiative hit in 2002. So I had 1 year of bliss. My nurse, Teresa, who she retired a few years ago, but she was with me for 21 years, and she and I weathered the storm together, because she remembers when that study hit the press, and it turned the way that we practice upside down. We had to really, really become even more of a staunch advocate for women and fight for what was right, and fight to be transparent about what the data really shows. So that is my job here today, is to be your advocate, to dissect out the data so that way you can make an educated decision about what matters. All right, There will be plenty of time for Q&A at the end, so please, I encourage your questions. I welcome your questions. I would love to hear what's on your mind. So we'll do that at the end of the morning in our Q&A session. So let's dive in and let's challenge those misconceptions and let's reclaim the truth about HRT. All right. So I see a lot of familiar faces out in the crowd, which is amazing, but what is equally awesome is that I see a lot of new faces. And for those of you who aren't familiar with the history of the Couri Center, I have been in medical practice, like I said, since 2001. And for the first 10 years of my career, I practiced both obstetrics and gynecology. And then in 2011, I made the difficult decision to step away from obstetrics, and I wanted to follow my true passion, which was to create a gynecology practice that prioritized not just treating symptoms, but I wanted to address the whole person. And I wanted to integrate my deep love of nutrition and lifestyle medicine into gynecology, recognizing that true wellness goes far beyond what's in any prescription bottle. And to expand my knowledge and expertise, I had to travel out to Arizona to complete a 2-year fellowship in integrative medicine with Dr. Andrew Weil. And then I also had to earn my certification in functional medicine because I needed a toolbox that had everything in it that I could provide the kind of care that I wanted to provide. In 2011, I had the distinct privilege of meeting Leslie Roosh-Bayer, who is now our registered dietitian, and so I brought her on to our team, and that further strengthened our commitment to this type of comprehensive root cause approach to women's health. And at that time, I cannot tell you how many fellow physicians told me, this will never work. That model of healthcare has never been done. And I don't know about you, but when someone tells a woman that they cannot do something, they better get out of the way while we're doing it. So back then, we truly were the black sheep. But with an incredible team of talented and like-minded providers and staff, we created a practice that puts the patient at the center, offering a level of care that was once considered unconventional. And now what's exciting to me is that the rest of the world is catching up and realizing the true value of integrative, functional, and personalized women's health care. So I'm super proud of what we've built, but I'm even more excited for what's to come. So that's just a little history of our practice. So now, disclosures. I have no financial disclosures. I do not work for any pharmaceutical company. I am not paid by any pharmaceutical company. The only admission that I have is I am a self-proclaimed nerd. I am a lifelong science junkie. I put myself through college working in the medical library at what is now Carl. To me, that was bliss. I could read every scientific article while I was at work, so it worked. But here's a photo of me at age 3. I think I was reading an atlas. I was dreaming of exploring faraway places, I guess. But in the end, I didn't stray too far. I built my clinic on the land of my childhood home, where I grew up here in Peoria and where I was born and raised. But I guess the real adventure for me has been the journey that my patients have allowed me to take with them, and that has been the one that's been the most fulfilling and rewarding of all. So let's dive in. My objectives today are pretty simple. I want to define menopause. I want to identify the challenges that women face during this phase of life. We're going to explore the data around hormone replacement therapy. But most of all, I really just want to stimulate free thinking and restore common sense, because so much of medicine and the medical treatment model these days, to me, has lost complete common sense. So what is menopause? Menopause, as you heard in the documentary, is the natural biologic process that marks the end of a woman's menstrual cycles and her fertility. And it typically occurs between the ages of 45 and 55. Now, technically, it is defined when a woman has gone 12 consecutive months without a period. The World Health Organization estimates that by the year 2030, there will be 1.2 billion women worldwide who are in menopause. And if we focus on the US, 2 million women enter menopause every year. One of my very favorite menopause physicians in the world is in England. Her name is Dr. Louise Newson, and she has been quoted as saying, "Menopause is not an end, it is an opportunity to grow, reflect, and make decisions about your health future." And I could not agree more, and I'm so glad that's why you are all here, to grow and be able to reflect and to make some good decisions about your future. So if we focus on the US, the median age of menopause in this country is about 51 and a half years, and there are 20 million women between the ages of 45 and 54 in this country. And to me, these figures highlight not only the large population of women in this country that are navigating this stage of life, but it also underscores the need to have appropriate and adequate healthcare resources for those of us at this time of our life, and to increase public awareness campaigns around menopause. So I made this slide intentionally simple for one reason. Menopause is 30 to 40% of a woman's life, and I want you to let that sink in. Probably one of the most commonly asked questions of me is, "Dr. Couri, how long does menopause last?" And I say, well, it lasts for the rest of your life. And their eyes get real big and they're like, wait, what? And I think what they're really asking me is, how long do the symptoms of menopause last? And I can say, well, like you heard in the documentary, for Caucasian women, hot flashes and night sweats tend to last 7.2 years. For African American women, they tend to last 10 years. But once we're menopausal, we are in it till the end. And that is why it's so important to make really, really good decisions and choices early on so that you can optimize this time of your life. So what are the most common menopausal symptoms? I think we all know hot flashes and night sweats are at the top of the list. But the physical symptoms that also can go along with them are headaches and vaginal dryness and joint pain. We may see palpitations or an irregular heartbeat, fatigue. We will start to notice some bone loss and possibly even osteoporosis. We may have a change in our body composition. Our weight tends to shift, or we may gain weight. But the psychological symptoms are equally important and equally bothersome as the physical symptoms, and they can be mood swings and difficulty concentrating, brain fog, low libido, loss of confidence, that's a big one, and loss of motivation. There was a study that looked at 22,000 women, and the study asked them what their top 5 most common menopausal symptoms are. And what they found were the symptoms are weight gain or body composition changes, brain fog or memory issues, anxiety and depression, sleep disruption, and Dr. Zalek is going to talk to us about that next, and then hot flashes. The thing that I like to tell my patients with menopause is much more than just physical and psychological symptoms. Menopause causes changes on the cellular level that can affect our ability to maintain optimal health. And what that means is there can be metabolic dysregulation when we go through menopause. And there was a study done of almost 87,000 women, and they were between the ages of 40 and 59. And this study identified the 8 most common conditions that increase by 45% in midlife. And they are as follows. Number 1, cholesterol tends to increase. Number 2, blood pressure tends to increase. Number 3, sleep disorders. Number 4, thyroid disorders. Number 5, GI issues such as acid reflux. Number 6, osteoarthritis. Our joints start to hurt. Number 7, other joint and connective tissue disorders, primarily frozen shoulder. And number 8, hot flashes. So as you can see, this list, number 1 and number 2, high cholesterol and high blood pressure, they are independent risk factors for cardiovascular disease, and cardiovascular disease is the number 1 killer of women. And so that is why it's so important not only to address hot flashes and night sweats, but really get serious about your metabolic health. All right, this is another very interesting syndrome that most patients are not aware of that can happen in menopause. It's called the musculoskeletal syndrome of menopause. And this term was coined by an orthopedic surgeon by the name of Dr. Vonda Wright. And this syndrome includes not only musculoskeletal pain, joint pain, muscle wasting or loss of lean muscle mass, loss of bone density with an increasing risk of fracture, increased tendon and ligament injury, frozen shoulder, like I mentioned, and the worsening of osteoarthritis. So think back about how many women get labeled as having fibromyalgia. And do you wonder if it truly is fibromyalgia, or do you wonder if it's because their estrogen is dropping? Estrogen is an incredibly anti-inflammatory hormone, and when you lose estrogen, things start to hurt. 70% of women in menopause will experience some degree of musculoskeletal syndrome of menopause. 25% of those women will have severe symptoms. And what's frustrating is that 40% of the time when women go and get an X-ray or an MRI to evaluate the pain, nothing is structurally found. And so what do you think happens? They're blown off. It's in your head, you're getting older, you'll be fine, ice it. No, it's estrogen. We've lost our estrogen. And if we could just educate all the primary care providers and orthopedists about this syndrome, it would make a huge difference in the quality of women's life. All right, general awareness, about, just in general, about how women have, what is their awareness, so to speak, of menopause. Well, there was a study in 2021, and it showed that 73% of women, 3/4, feel completely unprepared for menopause. And 58% of women report feeling blindsided by the severity of their symptoms. This statistic was staggering to me. 94% of menopausal women say they have never been taught about menopause. And I'm so glad that you all are here today, because you will not be in that statistic. So we're going to make sure you get taught plenty. Now, women do not have unrealistic goals during this time in life. The 3 goals that they really just want to achieve: they want to first alleviate symptoms, they want to second restore their quality of life, and they want to maintain daily functioning. I mean, we're not asking for a lot, right? I mean, this is just basic 101 quality of life. In 2024, a New York Post survey expressed or showed that 74% of women expressed a desire to learn more. So women are hungry for knowledge. Menopause is not just a physical or a psychological derailment, so to speak. It's not just about symptoms. It's a financial and economic issue as well. And they touched on that in the documentary. In 2021, there was a study that noted that menopausal symptoms are a leading cause of absenteeism and workforce attrition in midlife women. And like they said in the documentary, by the time we've hit menopause, we've pretty much worked our way up the ladder, right? We've kind of at that point in our career where we've made it. We've put in all the hard work. But if menopausal symptoms, brain fog, can't remember anything, can't sleep, if those things start to hijack our productivity and our ability to work at the best capability we can be, that's going to take an effect on our workforce performance. There was a study in 2017 that showed that 20% of women report that menopausal symptoms negatively affect their work performance, with a subset leaving the workforce entirely. And I just find that to be absolutely just heartbreaking to think that women have to leave the workforce because of not getting the help they need with menopause. $1.8 billion is the estimated cost to American women in lost working time per year due to the symptoms associated with menopause. All right, so if 3/4 of women want to learn more about menopause, where are they getting their information? Well, this might be interesting to you. 58% of women get their information from the internet, 47% from social media. Whether that's good or bad, I'll leave that up to you. An equal amount, 46%, get information from family and friends, 29% from traditional media, but only 25 to 34% get their menopausal information from their healthcare provider. And we need to change that. But unfortunately, a lot of times when they go to their healthcare provider, this is what happens. A significant number of women felt that their menopausal symptoms were dismissed or trivialized or inadequately addressed, with 75% of the women in the study saying that their symptoms that they felt were dismissed, 45% felt they were blown off, and 1 in 5 felt that their healthcare provider lacked knowledge. And they weren't wrong, because when we look at the education gap in around menopause, there was a study in 2023 looking at 99 OBGYN residency programs. So in order to become an OBGYN, we do 4 years of medical school and a 4-year residency program to become a women's health specialist. What this 2023 survey found was that only 31% of OBGYN residency programs provided any formal curriculum on menopause. And yet when we graduate and we go into practice and we're sitting across from patients in the exam room and they're asking us about menopause, we're expected to have the answers. 80% of medical residents admit feeling barely comfortable discussing or treating menopause. It's not any better globally. There was a study that looked at internal medicine residency and family medicine residencies. To be an internist or a family practitioner, you do a 3-year residency program after you've done medical school. What they found was that these programs had fewer than 2 hours of menopause education in 3 years. Yeah, it's shocking. 40% of practicing physicians feel inadequately trained to manage menopausal symptoms and HRT. So one of the largest knowledge gaps in women's health, in my opinion, involves menopause hormone therapy. There's no doubt that women face obstacles when they're trying to get access to HRT. In the United States, only 27% of primary care providers feel confident managing or prescribing hormones. It's not much better for OBGYNs. Only 44% reported feeling comfortable prescribing hormones. Same statistic globally. And 60% of physicians cited insufficient training in HRT. And this is where we really need to make some inroads and improve upon this, because it is a problem that is not going to get any better anytime soon. So there is no doubt that you cannot adequately, or there's no doubt that you can truly not take adequate care of a menopausal patient unless you have a really adept knowledge base on hormone replacement therapy, because hormone therapy reduces many, if not all, of the symptoms of menopause. It improves quality of life. It decreases many of the chronic diseases associated with menopause, and I'll show that in more detail on the next slide. It reduces the risk of heart disease and diabetes. It lowers the risk of bone loss and osteoporosis. And like Dr. Lisa Mosconi said in the documentary, if it started early, there's possibly neuroprotective benefits, meaning less risk of cognitive decline and/or dementia. So estrogen decreases the risks of all of these diseases. It reduces the risk of diabetes by 20%. It reduces the risk of heart disease by 30 to 50%. It reduces the risk of colon cancer by 45%. It reduces the risk of depression by 50%, better than any SSRI that I am aware of. It reduces the risk of hip fracture by 30 to 40%, reduces the risk of Alzheimer's by 35%. It reduces the risk of age-related macular degeneration, which is a leading cause of blindness, by 35%. And it reduces the rate of all-cause mortality by 30%. So if estrogen has so many benefits, what in the world went wrong? And for years, research has shown that estrogen helps protect women's hearts and brains and bones and overall health. So why did millions of women worldwide suddenly stop taking it in 2002? And what caused the fear and the confusion? Well, they mentioned it in the documentary. It's called the Women's Health Initiative. And the Women's Health Initiative was a study that the headlines came out of in 2002. And I'll talk about that study in more detail, because that's really what started this hysteria over the fear of HRT. So in July 2002, these headlines were plastered all over every newspaper and magazine in the US and around the world. A large federal study of HRT in postmenopausal women was abruptly halted because the drugs caused a slight but significant increase in the risk of invasive breast cancer. So if we look at hormone therapy usage trends in the United States between 1999 and 2020, you can see that in 1999, between 25 and 30% of eligible menopausal women were on hormone replacement therapy. And then the red arrow signifies when the Women's Health Initiative came out, and that was in 2002, and it started a precipitous decline in the usage of hormone therapy. And now the rates of HRT usage have never recovered, and they are 5% or less. So what was the Women's Health Initiative? Well, it was a very large study that was looking at how HRT diet and lifestyle affected menopausal women's health, and it focused on heart disease, osteoporosis, breast cancer, and overall well-being. The study began in 1991, and it was planned to run for 15 years, but the HRT portion was stopped early in 2002 due to concerns about health risks. It was a federally funded study. It was the most expensive study ever funded by the government, costing $1 billion. And it enrolled over 160,000 postmenopausal women. And the next statistic is really important. The average age of the woman who was assigned to start getting hormones in that study was 63 years old. But remember what I told you, the average age of menopause in this country is 51 and a half. We don't typically go around starting 63-year-old women for the first time on hormones. The initial findings of the study, published in July 2002, among women taking both conjugated equine estrogen, which is oral estrogen, used to be called Premarin, and oral medroxyprogesterone acetate, also called Provera. These were women who still had a uterus and needed both estrogen and a progestin. So the initial findings showed that there was a 26% increase in breast cancer, 41% increase in strokes, a 29% increase in heart attacks, and a doubling of the rate of blood clots. So of course, when women read these statistics, they were afraid. They threw their hormone replacement in the garbage. Our phones rang off the hook at the office, and I tried to pick up the pieces and try to figure out what this meant. One of my very favorite authors, Samuel Clemens, has been quoted as saying, "There are three kinds of lies: lies, damn lies, and statistics," and that's exactly how I feel about this study. And I'm going to break it down for you so you understand. So the one thing you have to realize in the world of statistics is how you can manipulate the numbers. So there is something called relative risk and absolute risk, and they're very different. So in the study, the placebo group, so the women who were assigned to take the sugar pill, 4 out of 1,000 women in that group developed breast cancer per year. In the women that were assigned to take the estrogen and progestin, 5 out of 1,000 women develop breast cancer per year. So 1 additional case of breast cancer per 1,000 women per year among the women taking the hormones. So that is a relative risk increase of 25%, which is what they reported, which sounded so scary. But the absolute risk was 0.08%, and that is not what was reported because that doesn't sound as scary. Several years after the WHI study, the lead author acknowledged, oh, by the way, there was no statistically significant difference in the rates of breast cancer among women who were on HRT and those who were on placebo. But that never got picked up by the media. So I wanted to make an analogy so you could understand relative risk and absolute risk. So I want you to imagine the risk of being struck by lightning in your town is 4 in 1,000 people per year. And then something changes. Maybe we get more thunderstorms, and now the risk is 5 in 1,000 per year. So that's a 25% relative increase, but in reality, it is still just 1 more person per 1,000. And I don't think that that increase would suddenly make you feel terrified of going outside. Probably not, because the absolute risk, 0.08%, remains very small, and it's all in how you manipulate the numbers. So when we look at the Women's Health Initiative, also called WHI, later follow-ups of the study found no increased risk of breast cancer. In fact, some data suggested a lower risk in women taking estrogen alone. And there was a long-term follow-up done in 2013 of that study, and it showed that the women who had had a hysterectomy who were taking estrogen had a 23% reduced risk of breast cancer. And if they did develop breast cancer while taking estrogen, they had a reduced risk of death from breast cancer by 40%. And again, those headlines never made the news. The question that I'd like to pose to you is, was the Women's Health Initiative population representative of women that we see who want to start taking HRT? Well, 2/3 of the women in the WHI study were overweight or obese, 36% had hypertension, 50% were current or past smokers, 2/3 were greater than 10 years beyond menopause, and like I said earlier, the median age of these women was 63 years old. So if I have an obese, hypertensive smoker who's 70 years old, I'm not probably going to start her on estrogen. So these women, this study was not exactly studying an ideal group of hormonal candidates. Okay, so what were the flaws of the Women's Health Initiative? I'll run through these quickly. Like I said, the age of the women in the study, the average age was 63 years, more than 10 years into menopause. And why does that matter? Hormones work best when started early in menopause, when our blood vessels are still nice and soft, before we have plaque buildup, while we are not hypertensive. Starting it late might not have the same benefits and could even pose risks. And what is the analogy? Imagine giving sunscreen to someone after they already have suffered a bad sunburn. It is not going to work as well. The study used synthetic hormones that differ from those commonly recommended today. So the Women's Health Initiative used what was most commonly used at that time, synthetic oral Premarin and Provera. But why does it matter? Well, those hormones are not the same as bioidentical hormones, which may be a safer alternative. And what's the analogy? It's like comparing freshly squeezed orange juice to orange-flavored soda. They are not the same thing. The study focused on the wrong group of women. 70%, like I said, were overweight or had high blood pressure, which already put them at a higher risk of heart disease and stroke. And why does it matter? Well, the study's findings don't apply to our younger, healthier women who would benefit from hormones the most. And what is the analogy? It's like studying how running affects fitness, but only testing it on people who never exercise. The results won't apply to everyone. The study was stopped too soon. The Women's Health Initiative was stopped after 5 years because of those misleading concerns about breast cancer. But why does that matter? Well, we find out that breast cancer risk was exaggerated, but the heart benefits of taking hormones take longer to show up than 5 years. So it's like quitting a marathon at mile 10 and because you're assuming the race is bad for you, when in reality, you just didn't finish the race. And lastly, the media spread fear instead of facts. So you saw the headlines. The Women's Health Initiative initial headlines screamed, HRT causes breast cancer and heart disease, and this created panic. And why does it matter? Well, like I said, the actual risk increase was tiny, less than 1 extra case of breast cancer per 1,000 women, and no increased risks of deaths from breast cancer, and that was never in the media as well. Okay, so now we're gonna finish up with talking about what are the truths about hormone therapy. This is my favorite part. So, truth, reduction of vasomotor symptoms, hot flashes and night sweats. What is the evidence? HRT is the most effective treatment for hot flashes and night sweats, reducing their severity and frequency by up to 90%, which is huge. I know nothing else on the market that will reduce hot flashes by 90% other than estrogen. Now, when I bring you evidence, I bring you receipts, and the receipts are the references at the bottom of the slide. And so I didn't make these numbers up. I didn't make up these truths. These are all from reputable scientific articles. Prevention of osteoporosis and fractures. What is the evidence? Estrogen therapy maintains bone density and reduces fracture risk by 30 to 40%. I think most women aren't aware that hip fractures cause as many deaths in this country as breast cancer each year. And thank God we've made huge, huge advances in breast cancer treatment. And the vast majority of women, well over 95% of breast cancer patients, survive. Hip fracture, not so much. Within the first year of a hip fracture, there can be a death rate of 50%. So I take bone health very, very seriously. Cardiovascular benefits when started early. What's the truth? When initiated in early menopause, and that is younger than 60 years of age or within 10 years of menopause, HRT is associated with a 30% reduction in coronary artery disease and a significant decrease in all-cause mortality. And again, cardiovascular disease kills more women every year than breast cancer. Estrogen reduces all-cause mortality. What is the evidence? Like I said, initiated in women at younger ages, younger than 60 or within the first 10 years of menopause, HRT significantly reduces all-cause mortality, all causes of death, and cardiovascular disease. And the magnitude and type of risks associated with HRT, including breast cancer, stroke, and blood clots, are rare, less than 10 events per 10,000 women, not unique to HRT and comparable with other medications. Protection against type 2 diabetes. What's the evidence? HRT improves insulin sensitivity and reduces the risk of developing type 2 diabetes by 20 to 30%. The rates of type 2 diabetes and prediabetes in this country are skyrocketing. Estrogen improves how our insulin binds to our cells and how our insulin works. So that is the mechanism behind why diabetes rates are decreased in women who are on estrogen replacement. Cognitive protection and reduced risk of dementia when started early. Like I said, estrogen therapy when started before age 60 may reduce the risk of Alzheimer's disease and cognitive decline. Estrogen does not increase breast cancer risk. It may actually reduce it. What is the evidence? Women who have had a hysterectomy and took estrogen alone, like I said, had a 23% lower risk of breast cancer compared to those who took a placebo. And like I said earlier in my talk, those who did develop breast cancer while taking estrogen had a 40% lower risk of death, mortality rate, than women who were not on estrogen when they were diagnosed. The other interesting thing is, and I didn't put this in a slide, there have been 25 studies done looking at women who had breast cancer, but then because of they were suffering so badly from their menopausal symptoms, decided to go back on estrogen after they were diagnosed with breast cancer. 25 studies. 24 of those studies showed no increased risk of breast cancer recurrence and no increased risk of death from breast cancer. And the one study that did show an increased risk, it's called the HABITS trial. It wasn't a very well-run trial. One of the major flaws is they didn't even require a woman to get a mammogram in that study before she went back on estrogen, so we don't know how many of them actually had a breast cancer recurrence before they started the estrogen. Okay, so it's the consistency of scientific data. And this is what I just want to point out. We have a treasury of scientific data over the years showing the safety of hormone replacement therapy, and it was hijacked by one study in 2002. Between 1975 and 2000, there were 45 published studies looking at the relationship between breast cancer and estrogen replacement. Of those, 82% found no increased risk of breast cancer, 13% found a very small increased risk, and 5% found a decreased risk. Among women who still have a uterus and have to take progesterone along with their estrogen, there were 20 studies between 1975 and 2000 looking at the risk of breast cancer, and 80% found no increased risk, 10% found a slight increased risk, and 10% found a decreased risk. One of my very favorite hormone researchers, Dr. Susan Davis out of Australia, says this: at a population level, obesity is having more impact on breast cancer risk than use of menopausal hormone therapy. And I will tell you, I agree with this, but I also think you could substitute any number of things for the word obesity. Microplastics, toxins, too much sugar, our diet, insulin resistance, you name it, I think you could plug in any number of things. But estrogen always gets the blame. Okay, back to our truth, and we're almost done. Vaginal estrogen decreases the risk of urinary tract infections. There was a study that was done on menopausal women, and it found that women who use vaginal estrogen cream or a vaginal estrogen tablet reduce their risk of getting bladder infections by 52%. And for anyone who's had a bladder infection or has had a mom or a grandmother that get a bladder infection or recurrent bladder infections, urosepsis, or women getting sick because of a bladder infection, getting very sick, is not a laughing matter. So this is a huge advancement. Progestin is not the same as progesterone. What is the evidence? The small increase in breast cancer risk in the WHI was possibly linked to synthetic progestins, also called Provera, not estrogen itself. Studies suggest that bioidentical progesterone may be a safer alternative and has not been shown to increase breast cancer risk. Okay, now we're getting on to my favorite truths. Testosterone improves sexual function and desire. What is the evidence? Studies show that testosterone therapy improves libido, sexual arousal, and sexual satisfaction in postmenopausal women with low sexual desire. Truth, testosterone supports bone health and prevents osteoporosis. What is the evidence? Testosterone plays a key role in bone density, reducing fracture risk in menopausal women. What is the truth? Testosterone boosts mood and mental clarity. Testosterone works by increasing the production of serotonin in our body. So for anyone who's been on an SSRI to block the reuptake of serotonin, you'll understand that improving the serotonin, the amount of serotonin in our brains usually improves mood, reduces anxiety, lessens depression. Testosterone is a brain hormone. It not only improves serotonin, it increases the production of melatonin, and that is why people on testosterone tend to sleep better. So testosterone therapy has been shown to reduce depression, anxiety, and brain fog in menopausal women. It also improves the body's ability to produce dopamine and norepinephrine, and those are our feel-good neurotransmitters. Testosterone supports heart health. What is the evidence? Higher testosterone levels are linked to better cardiovascular disease and a lower risk of heart disease in women. Dr. Traish out of Boston, he's a PhD. He studies everything under the sun regarding testosterone. He's an absolute brilliant PhD. He has written numerous articles about testosterone and its potential link to breast cancer. Not one of the studies that I have read about testosterone has shown an increased risk of breast cancer. What is the evidence? Testosterone does not increase breast cancer risk in women. The evidence indicates that testosterone may actually have a protective effect by inhibiting tumor cell growth. Truth, testosterone is not just for males. There was a study done in the Lancet Diabetes and Endocrinology Journal, and it reviewed 36 randomized controlled trials of over 8,000 women. And the study refuted the myth that testosterone is only for men, demonstrating its essential role in female health. When I put my patients on testosterone, the feedback that I hear the most is, "You've given me my life back. I feel like myself again. And my brain is finally working again." So that's the feedback that I hear, and it's very, very rewarding to be able to see women thrive again. Okay, so back to fear. Fear of breast cancer is the most common reason that women are apprehensive about HRT. I hear it in my office all the time. We, as healthcare providers, we play a crucial role in addressing these misconceptions and helping women make informed decisions about menopausal treatments. That Women's Health Initiative and the fear that it invoked stole 20 years of potential health benefits from women worldwide, and it's time to take those 20 years back.
On my soapbox, that's really the beef I have with the HRT stuff. The absolute megaphone of fear that was promulgated through estrogen hysteria in 2001. And even though if you read the fine print today, many of those people have walked back those recommendations of estrogen avoidance. But again, it's not only is it too little too late, you've got a generation of women, literally a generation of women, over 20 million women who have been deprived of HRT. But even women that are available or eligible to take HRT today, they're still confused because the same megaphone that was used to say estrogen will give you breast cancer is not being used to correct course. So there's an enormous asymmetry in these information campaigns.
One of the guys in that committee, in the investigative journalism I did around the HRT dogma, before the announcement, there was a committee meeting where they were hoodwinked. And the 40 investigators were basically told, hey, throw out the agenda. We've got some breaking news on this study. Causes breast cancer. We have already submitted the journal. It's coming out. And a bunch of guys there are like, what the heck? This is not how we do research, right? One of them, Bob Langer, who I interviewed, had said in a shouting match with the lead investigator, he said, look, if you put something out there as sensitive as breast cancer is caused by HRT, if you will never be able to put that genie back in the bottle. And that's exactly what happened. And sure enough, that guy had confessed to me that it did not cause, there were no increase in breast cancer deaths.
Yeah, not a single increase in breast cancer deaths.
Unbelievable.
And that was at the time of publication. That was again demonstrated 9 years later, and again demonstrated 20 years later on the follow-up of the same cohort.
There's probably no modern day medical intervention that has improved the health of a population as much as HRT for postmenopause.
So that's Peter Attia talking with Dr. Marty Makary. Dr. Makary is going to be the head of the FDA now, so hopefully he can kind of distill out some of these misconceptions and help women have greater access to HRT. Okay, I'm going to wrap up. So, like I said, we have a treasury of studies that have been done over the years that we can use to validate the safety of HRT, because waiting for more studies to be done is not going to be the answer. And the harsh reality is that the amount of research funding that gets directed towards women's health is dismal. And an even smaller fraction gets allocated to menopause research. In 2021, the NIH reported that $5 billion in US federal funds was allocated to women's health research, but only 0.003% went to menopause research. So we have to rely on the studies that we already have, because they're good and they're solid, and they can definitely correct the misinformation that the Women's Health Initiative delivered. Nature magazine in January 2025 identified the challenge: menopause research is globally underfunded, and it is time to change that, and I do agree with that, and I hope we do see that change. Wrapping it up, putting it all together, the Menopause Society emphasizes that HRT is an effective and safe option for most healthy women under age 60 or within 10 years of menopause onset. Individualized care, considering personal risks and preferences, is critical to maximizing benefits and minimizing risks. I don't want everybody to think that I put every single patient on hormone replacement therapy. I do not. Every patient is her own individual. She has her own individual risks. My job is to do a deep dive into what those risks are and make sure that she is a good candidate. Every woman that comes into our office gets a breast cancer risk score calculated. Every woman gets her cardiovascular score calculated. And we look at that data and say, okay, let's factor that into the decision of whether you're a good candidate for menopause. It's definitely not a one-size-fits-all. I want to just end with this slide. Instead of asking, Dr. Couri, is HRT safe? I think a better question may be, what are the risks and benefits for someone like me? How does this compare to my other options? What do I gain by saying yes? But I think the more important question is, what do I risk by saying no? So, with that, I hope you enjoyed that talk. I really am grateful again to be here and present that data to you. We're going to take a short break, and then we'll be back in about 15 minutes. So thank you all.